just for the record, I mean, I would note that the actual statutory standard is whether the rate is affordable and then promotes access to care and promotes quality care, just for the record. Does MVP have any internal metrics or benchmarks to gauge whether a proposed rate is affordable?
I think the answer to that would have to be no. We don't have anything that directly determines whether or not a rate is affordable.
Okay. And as an actuary, do you feel competent, and I'm using that in the legal sense, to testify about whether a rate is affordable?
Jack, it calls for a legal conclusion. He's not a lawyer.
I believe we heard testimony about your qualifications as an actuary earlier. Are actuaries trained to judge affordability?
I would say
so. You're just so we're clear on the record. So you're withdrawing the question and asking a different question, Charles. I don't want to.
Yeah, I think that's what I did, Mr. Carnegie. Yes.
Thanks.
Specifically, no. There's no actuarial training for determining whether a rate is affordable.
Okay. All right. So I am going to go through, as I said, a few of your responses. There is not a lot of overlap with what we've gone over previously. So let's get started. If you could turn to page 13, which has question 27 on the page. Are you there?
Yes.
And question 27 reads, what steps does MVP take to manage costs and contracts to improve affordability? Is that right?
That's correct.
Okay. And you said beginning on line 12, MVP negotiates rates that reflect appropriate reimbursement levels across all provider types in MVP's network. Is that what your testimony was?
That's correct.
Okay. Quickly, if I could have you turn to Exhibit 1, which is your actuarial memorandum, specifically page 5 of Exhibit 1.
Okay.
And I'm not using the Bates numbers appropriately here. Oh, uh-oh. If I could take a second here, I actually mean I would like to refer you to, it's page 5 of the actuarial memorandum, Bates stamped page 37. I'm sorry.
Okay. I am there.
Okay. So under the heading medical trend factors, the second paragraph, could you read the first sentence there beginning for Vermont providers?
I don't see a medical trend factors on Bates page 13. Is it Bates page 11, page 3 of the memorandum?
Okay, let's pause for a second. This is my fault. I told you I was going to use the Bates numbers and then I didn't do it. So we're on Exhibit 1, Bates page 37. 37, I'm sorry.
Okay, I'm there now. Thank you.
Yeah, you found medical trend factors in the middle, around the middle of the page?
Yes, that's correct.
Okay, so could you read that sentence beginning for Vermont providers?
For Vermont providers whose contractual reimbursement changes are governed by the Green Mountain Care Board, MVP is reflecting the Green Mountain Care Board's most recently approved budgeted changes as the unit cost trend for 2024. We are using 2024 increases. Oh, sorry.
Yeah, and I'm sorry. Yep, that's perfect. I just wanted you to read that first sentence. A lot of work for not very much, because I'm going to have you flip now to Exhibit 24. Sorry for having you flip around here.
Okay, I'm there.
And on page 2, so these are charts showing your derivation of medical cost trend by facility. Is that accurate?
That's correct.
And while most of the information on this page is confidential, the notes column is not confidential. Is that accurate?
That's correct.
Looking at this page, what is the most common note you see?
The most common note I see would be the Green Mountain Care Board rate effective 10/1/2023.
Okay. So taking into consideration this information here and what you read from your actuarial memorandum on page 5, would it be reasonable to conclude that MVP is largely not able to negotiate rates for GMCB regulated entities below the GMCB ordered rate cap?
I'm not involved in our contracting directly, but that's my understanding from discussions with our network team.
And I think I heard you testify earlier that the hospital budget rates are perceived as a floor, not a ceiling. Did you say that just a little bit ago?
That's generally true, correct.
Okay. Thank you. Again, we're going to shift gears here again back to your pre-filed testimony, which is Exhibit 16. If I could have you turn to Q30, which is on page 16.
Okay.
Okay, and so Q30 here reads, how does MVP increase affordability by helping lower the cost of premiums for subscribers? Is that right?
That's correct.
And this is one you actually did go over earlier with your attorney. Do you remember?
Yes.
Okay. And I just want to preface this here by saying okay, not strike that. I'm gonna strike the preface and just go into my questions. Is it fair for me to say here that to summarize your response as MVP helps its members to get PTC and enroll them in cost sharing reduction plans when they are eligible? Is that in essence what the response is here?
I would say that the response is partially that and also partially that we participate in these programs, which enables members to obtain those things.
Are you able to not participate in the programs?
I don't think so, but that is
okay. All right.
We are still doing it.
Yep. Is it fair to point out too that the PTC, the premium tax credits and the cost sharing reductions only exist in the individual market? Is that accurate?
That is true.
And in the small group market, employers and employees share the full cost burden of any premiums and premium increases. Is that a fair statement?
That's correct.
Okay. Back to the substance of the response, there were a few things in this response that I found confusing, and so I want to ask you about them, and hopefully we can clarify them. And actually, I think it's going to make the record clearer here. The figure 500% FPL comes up 3 times in this response, and it's not immediately clear to me why. So for example, on line 20 of page 16, it says MVP reduces out-of-pocket costs for enrollees and earning from 100% to 500% of the federal poverty level through cost-sharing reductions. Do you know the FPL level that the cost-sharing reduction plans end at?
Yeah, I believe that should say 300%.
Okay.
Specifically related to the cost sharing reductions.
Okay. If I pointed out that the CSR plans go up to 250 FPL and that Vermont premium assistance goes up to 300%, I think that might be what you're referring to as well. Does that sound familiar? Does that sound right to you?
Yes.
Okay. All right. And the next reference, so that clears up that one. So that 500 should be 300. That's fair. The next reference to 500 FPL is line 2 on page 17, which reads, furthermore, individuals earning at or below 500% of the federal poverty level qualify for APTC. Did I read that sentence correctly?
That's correct.
Okay, and the way I read that, it sounds like 500% is a cutoff or a cliff for PTC. Is that accurate?
That would be accurate. That would be my understanding.
I'm tempted to want to do some more math with you because, and this is a good thing for MVP. I mean, the PTC goes higher. It is based on the benchmark plan. We know that premium tax credits are based on the benchmark, correct?
Yeah, it's based on the second lowest cost silver plan.
Exactly,
Correct.
which in 2023 was, do you happen to know roughly what the benchmark cost in 2023?
Not off the top of my head, no.
Okay. If I told you it was around $900, would that sound accurate?
I would have to take your word for it. I'm not sure.
Okay. Again, this is just for the sake of trying to clarify the record, this is not a gotcha for MVP. I mean, the PTC goes higher, which is beneficial for your members. And if I told you it was close to 850% FPL for this year until the premium subsidies potentially expire, would you agree that that sounds fair?
I'm not 100% certain. I will take your word for it.
Okay. All right. I'm going to move on to my final section of questions. And thank you for bearing with me. If you could turn to page 14 of your pre-filed, which has on it question 28.
Sure.
So this question is, how does MVP managing prescription drug utilization improve affordability, access, and quality of care? Did I read that accurately?
That's correct.
Okay. Could I have you read the third sentence in your response? So that's starting on line 8 with the words cost containment.
Yes. Cost containment estimates in the MVP filings are based on our PBM's proven track record.
Okay, thank you. Now, if you could turn to Exhibit 19, and specifically page 9 of Exhibit 19. Are you there?
Yes.
Okay. So first, do you recognize this exhibit?
I do.
Okay. It's L&E's memorandum about your MVP's 2025 individual rate filing.
That's correct.
Okay. And in the top of the page here, there is a chart entitled Historical Allowed RX Trends. Is that accurate?
That's correct.
Okay. And in your testimony today, I heard you say that L&E, I think you phrased it, undertook a study comparing your PBM's projections of RX trend to MVP's actual utilization or actual trend. Was that your testimony earlier?
That's correct.
All right. And this table that's on page 9, is this the study that L&E undertook?
These are the
That's what this
results
table
of that
is?
study.
The
Yes.
results of it. Okay. I also believe I heard you say earlier in your testimony that historically, when setting your RX trend in these filings, that MVP has relied on the trend provided by your PBM. Is that accurate?
Yes.
And I think you said that you relied on your PBM's trend data with the understanding that they understand the market better than we do. I think you said something along those lines. Is that accurate?
Yes, that's correct.
Okay. And that reliance on your PBM's trend is consistent in a way with your pre-filed testimony. Would you agree that your PBM has a proven track record? Would you agree?
That's correct.
Okay. So if I'm interpreting this chart correctly, in the fourth column, it shows that your PBM has actually consistently under projected MVP's RX trend. Is that accurate?
That is a fair statement.
Okay, and when we talk about an under projection, does that mean your prescription drug costs were actually higher than your PBM predicted?
That is true.
Okay. And so the best guess at RX trend that your PBM provided you in the 4 years listed here on this chart was an under projection of 7.6%. That was their best guess. Is that fair?
That's correct. The lowest number in this table is an under projection of 7.6%.
Okay. Meaning that in that best guess year, MVP's prescription drug claims were 7.6% higher than what your PBM projected. Is that correct?
That's correct.
All right. And overall, on a 4-year average, how much higher was MVP's actual RX trend than what your PBM predicted?
It would be approximately 10.6%, as shown in this table.
Okay, thank you. And as a result of these under projections, L&E is actually recommending that MVP not rely solely on CVS Caremark's provided trend, but that it blend the PBM provided trend with the 4-year average of actual RX trend. Is that what L&E is recommending here?
Well, that's my understanding of their recommendation.
Okay. And as a result of that recommendation, the RX trends in this filing go up significantly from 7.4% to 13.1% in the individual market. Is that accurate?
That's correct.
And in the small group market, that number is just slightly different. It goes from 7.3% to 13.0% in the small group. Is that accurate?
I would have to look at the...
Yeah, I'm sorry. It's Exhibit 20, page 7.
to 13%.
Okay. Thank you. Which increases the overall rate, the effect of that. And I think we've heard testimony about this before today. It increases the overall rate 1.2% in the individual market. Is that right?
That's correct.
And was it 1.4% in the individual market based on MVP's calculations?
I believe so. Yes.
Do you know how much additional premium is represented by 1.2% and 1.4%?
Based on Exhibit 27 for 2024, we have $250 million in allowed premium, roughly. That's projected. So that would be 1% of that would be approximately $2.5 million. So it would be somewhere in the neighborhood of $3.5 million.
So, thank you. L&E recommends that you not rely on your PBM's trend data alone, and asks you to ask for roughly $3.5 million more in premiums to cover prescription drug claims. Is that accurate?
That's correct.
Okay. Which you agree with. I mean, MVP has modified their rates to incorporate L&E's recommendation. Is that accurate?
Yes.
Okay. But when you filed the rates, you were perfectly comfortable relying on your PBM's track record and to rely on their trend, the trend that they provided. Is that accurate? When you filed the rates?
Yes, I would say that both are reasonable estimates of pharmacy trend.
Okay. And those original trends, when you filed the rates and you submitted the rate filing, you thought that original trend produced actuarially sound rates. Is that accurate?
That's correct.
Okay. I'm going to take you to Exhibit 12 now. And to page 2 of Exhibit 12. So do you recognize this exhibit as your responses, MVP's responses to questions from my office?
That's correct.
Okay. And do these responses look familiar to you?
Yes.
Did you personally draft them?
I did, with the support of our pharmacy team.
Okay. So just looking at question 5 and just taking the first subpart A, And it asks, prior to renewing with CVS Caremark, did MVP audit CVS Caremark's performance under the prior contract? If so, describe all aspects of the audit. Did I read that correctly?
That's correct.
Okay. And could I have you read your response to that subpart? It's the first two sentences of the response.
That response is marked confidential. I don't know if we need to. I would like to note
Is
that.
you might have an outdated version of the
Oh,
binder because
I might, yeah.
Mr. Carnegie, could you confirm that the response to question 5 is not confidential?
I can confirm that my copy of it doesn't have a red box around it. But I want to be careful, Charles. So I think you're correct, but Eric, what are you looking at? And when I say that, are you concerned about those first two sentences having something confidential that we've just made an error in marking this?
I think I'm relying on the binder that you sent me a week or so ago. So if there was a determination made on the confidentiality of this document since then, I might be relying on an outdated copy. So
I
if
think
you
we're
have the
okay.
most...
I think based on that, and thank you, Charles, I think you're fine.
Okay,
Thank you to answer the question.
Sure. So I'm sorry, you wanted me to read the first two sentences?
That's correct. Yep.
Okay. MVP does audit its PBM. MVP has audited claims and rebates as part of the audit process.
Okay. So you were asked to describe all aspects of the audit. Do you feel that this was, in your opinion, was this a full and complete response to the question?
I would have to say yes.
Okay.
This is our response.
Okay. So the sum total of your audit was that you audited claims and rebates. That's your testimony.
That's correct.
Okay. So you did not audit fees charged by your PBM to ensure they align with the contract?
I did not perform the audit, so I can't speak to whether or not that specifically was done as part of the audit.
Okay. So your response was that you audited claims and rebates, and in your testimony here today was that that's your full and complete response, and you're not able to speak to any more specifics because you were not a participant in the audit.
That is a fair statement.
So you wouldn't then also be able to, and it would probably be confidential, to tell us how much MVP has recouped from CVS Caremark as a result of its audits. Is that fair?
That's also correct. I would not be able to provide that answer.
Okay. You could go through a similar exercise with subpart B of the question, which asks whether MVP has performed any market comparison checks prior to renewing with CVS Caremark, and if so, to thoroughly describe the process, including the timelines, evaluation criteria, and benchmarks. Could I ask you to read your response to subpart B, which are the third and fourth sentences in your answer?
We also perform periodic market comparisons to ensure we have competitive PBM pricing terms. This process includes hiring a consultant who will compare the key aspects of services and pricing to the market, similar size plans and lines of business.
So it sounds here like you hired a consultant to do the market comparison checks.
That's correct.
So probably then similar to your the audit where you were not a direct participant, are you not able to speak to any additional details about the market comparison checks?
That's correct. I'm not able to speak to any additional details.
Okay. Could I have you turn back to exhibit, page 3 of exhibit 12. Oh, yeah, okay. We're on the same exhibit, page 3. Next page.
Sure.
Okay. We asked you about a new drug pricing model offered by your PBM called TrueCost, and I explained at the beginning of the hearing that we had included a non-stipulated exhibit. I'm not going to ask you anything about that non-stipulated exhibit. I'm just going to ask you one simple question, and it's that if MVP members are not paying the true cost of drugs now, what are they paying?
Just going to object, object to the form of the question just because it's referencing true cost with a capital T and a capital C. And I would ask you just to clarify what you're actually asking the witness.
So
Yeah.
what I'm asking the
Okay.
witness is, I'm sorry, Mr. Barber.
No, you were going ahead, so that didn't mean to cut you off.
Okay, all right. The question is, if MVP members are not paying the actual acquisition cost plus a dispensing fee of the drug, which I understand to be the case, what are they paying?
I would have to answer that. I don't know that. I would have to get back to you on that. I'm not a pharmacist, and I don't have expertise in that area.
All right, it's fair enough. We're going to go back to, and this is my final set of questions here. We're almost through it. Still on the same topic of PBMs. Turning back to Exhibit 16, page 14, and back again to your response to question 28. Are you there?
Yes.
Could you read the second sentence in your response beginning on line 6, at the very end of line 6?
MVP has contracted with the same highly regarded and competitive PBM for several years to obtain the best prices on prescription pharmaceuticals.
Okay, thank you. You were asked earlier today whether actuaries choose their words carefully, and you agreed. Is that accurate?
That's correct.
Okay. As an actuary for a health insurer, is it a part of your job responsibilities to keep up on current events in your industry?
Yes, but ones that directly relate to my job as a health insurance actuary working in the commercial space.
Okay. Are you aware? I mean, did you see in the news that last week the Vermont Attorney General filed a civil complaint against CVS Caremark, alleging that PBMs drive up drug prices and harm insurers and their consumers?
I was not aware of that.
Okay. Did you see in the press any reporting, or did you read the report that was just issued by the Federal Trade Commission that was entitled Pharmacy Benefit Managers, the Powerful Middlemen Inflating Drug Costs and Squeezing Main Street Pharmacies?
I did not.
Okay. All right. Thank you very much. That's the end of my questions.
Okay, so we'll move to board questions next, but does anybody need 5 minutes bio break or anything? See a couple of people nodding their heads, so why don't we take a couple of minutes? We'll come back at 11:25. So if we could go off record, and I'll see everyone back here then. Thanks.
We're off the record at 11:18 a.m. Our report is ready.
Thank you. Looks like we're all back, so let's go back on record, please.
Okay, we are back on the record. The time is 11:26 a.m.
And we'll start with board questions with Board Member Walsh. Tom, you're on mute.
Thank you, Mr. Barber, and good morning, Mr. Bachner. Thanks for your testimony so far. I'd like to start with a couple questions about medical trend. The first one, we could refer to the binder. It's in Exhibit 1, page 11. There's a comment under the utilization trend about the analysis, the findings of the analysis being too volatile to use. And I was wondering if you could just explain that a little bit more, please.
Sure. So we take our claim data over a long period of time, and we attempt to adjust for things like demographic changes, changes in benefits, all different variables within the market. And then we plug that data into a statistical analysis software that will spit out, basically does a time series modeling of what we expect future trends to look like. And within that time series, there are variables of confidence and variables of variability. So it'll spit out a best estimate trend number, but then it'll also have a range around that. And so when the range is sufficiently large, then we can say that the data is volatile, and it would be, while we could pick a point estimate, it could reasonably fall within a large range of possible values.
And if we could, thank you for clarifying it. If we were to look into the trend figure a bit further, what is the trend composed of?
Sure. So currently we run our trend forecasting models at 3 different levels. We run them by service category. So it would be inpatient, outpatient, and physician. So inpatient, we run it at, I believe it's days per 1,000. An outpatient and physician would be visits per 1,000. And we do carve out certain services from that, things like vaccines or durable medical equipment, things that are not necessarily visits, and try to focus on the core visits within each of those service categories.
In this is your first time with us. This is my 3rd time through this, so I'm still learning as well. My understanding of the trend is that the trend is built over a long period of time and then tries to forecast or looks at the price per unit and the number of units, and then the coding associated with each unit. Do I understand that correctly?
So specifically related to our trends, this trend here focuses on utilization. So that would just be the number of services performed.
Okay.
And our unit cost trends would be the cost per unit for a given unit. MVP has not historically done any sort of trend for intensity, which I think is what you're describing, sort of the third rail of trend, where the cost per service is not necessarily increasing, and the number of services is not necessarily increasing, but the average cost per service is going up over time.
Okay, that's not been part of MVP's approach in the past.
That's correct. We're certainly
Okay.
continuing to evolve our medical trend forecasting, but that's not historically been a part of it.
Okay, thank you. Of the cost and the utilization trends, which has been the largest driver in premium prices over the past several years?
So in terms of our premium increases, generally unit cost trends are higher than utilization trends. So we see the cost of services going up faster than the utilization trends. Now, as to what's actually been experienced, I can't say for certain which one is higher.
Okay. So in MVP's analytic approach, it's not your approach to try to apportion which is driving a greater percentage than the other.
That's correct. We view medical trend holistically as one number that's made up of utilization and unit cost components.
Okay, okay. Do you do that analysis at the hospital level, or is it only at a region level?
It's only at a regional level and specifically a line of business level. We found that utilization trends at the hospital level are even more volatile than the utilization trends at a market level. So it would be difficult to say one hospital is going up more than another.
Okay, okay, that's helpful. You had mentioned in part of your testimony, I didn't get the specific page number, but there was discussion of GMCB regulated entities and non-regulated entities. And I believe the number that I heard was that GMCB regulated entities account for approximately 45%.
Yes, that would be correct. They account for 45% of the total medical cost
of the claims.
Correct.
Do you know, are the utilization and cost trends behaving similarly in the GMCB regulated book of business and the non-regulated book of business?
I do not know off the top of my head. I would have to get back to you on that one.
Okay, that'd be helpful. I'd like to switch to the risk adjustment transfer.
Sure.
For a moment. If another carrier in the state, or if members left another carrier in the state and came into MVP, how would that be addressed, or what are the issues that concern you if that were to happen?
Sure. So I guess it depends on if we're talking about a few members or functionally all of the members. If a few members move, and we see members move every year between carriers, there is uncertainty in terms of the risk adjustment because we don't necessarily have the risk adjustments based on claims diagnosis codes for a given time period. So if we don't have claims for that member, historically, we can't say, well, this member should have this diagnosis, but they actually don't. Or this member hasn't yet been diagnosed with a condition because they haven't seen their primary care doctor in a given year. So there's usually a lag in terms of risk adjustment for the first year that a member joins a carrier. There would be, if all of the members were to move, let's say, to one carrier or the other, that would be very difficult from a risk adjustment perspective because the risk adjustment is designed to be a zero-sum game. So it's designed to move money from some insurers to other insurers to level the playing field. Well, if one carrier becomes the market, then the market is truly representative of all of the claims, and that one carrier, there's nobody to deal with adverse claim impacts and adverse risk adjustment impacts. Does that answer your question?
Yeah, that's helpful. It's helping me understand some of the uncertainty that you face. And so when a few members switch, their claims from the prior affiliation, those claims don't come over. You don't know what their healthcare needs are going to be.
That's correct. Yeah, the risk adjustment model is specifically based on diagnoses that are on claims within the given year. So right now, the risk adjustment results that were just released were for 2023. So claims that had, or diagnosis codes for members that were on claims in 2023. So if a member goes to their if the member is new to MVP in 2023, for example, they go to the doctor and they get properly diagnosed with a condition, then everything's all good. But the problem becomes if a doctor, for whatever reason, doesn't code that diagnosis or hasn't coded it a couple of years ago but didn't code it this year. If a member is ours for a longer time period, we're allowed to do things like chart review, which is where we can go and actually pull the member's medical chart and access claims from the prior year to say, hey, this member had diabetes, as an example. Can we go to the provider and then say, do you think this member still does have it? And then we can get that on the claim. So for a new member, we lose out on the ability to look back at our own historic data and make a determination about a member's condition.
In your experience, are members who switch, is there a pattern? Do they tend to be healthier or less healthy?
They tend to be healthier, all else being equal. And that has less to do with market dynamics and more to do with members who are sicker are generally receiving care. And unless they have a really bad care experience, they generally want to receive the same care. So they want there to be minimal disruption. So to use an example, if somebody's receiving a chemotherapy drug and they know that MVP is covering it, well, they're less likely to move and have to try to go through, prior authorization or whatever it needs to be to switch to a different carrier.
Thank you. Also, in your earlier testimony, you discussed the UVM letter from last Friday requesting an increase in their budget, and the calculation had been that if that increase were granted, that would necessitate a 0.4% increase in your rate request. Is that correct?
That's correct.
Okay. I would imagine that's the largest organization in the state. So if a similar request had come from a much smaller facility, what would that do to that 0.4 number? Would it go up or down?
Yeah, so it would go down. I'm looking at one of our exhibits right now, Exhibit 24, where we list out the percentage of claims that are at each of the facilities, and to use, actually that number has been deemed confidential, so I don't want to use it, but in general I would say yes, it would go down if a hospital with less utilization asked for a rate increase.
Yep, okay, thank you.
And I'm happy to provide more color in executive session if we need to, but.
Okay. No, I asked that earlier. Okay. Finally, you discussed with your attorney the topic of cost shifting.
Yeah.
Is your understanding of that as a hospital has a larger proportion of patients with Medicare and Medicaid, their commercial prices would need to be higher?
Assuming that the Medicare and Medicaid fee schedule increases are not adequate to cover the cost of providing care for those Medicare and Medicaid members, then yes.
Okay. Are you familiar with the meta-analyses done to look at that question?
I'm not particularly familiar with that now.
Are you familiar with the CBO analysis from 2022 looking at that question?
I'm not.
Are you familiar with the RAND 5.0 series of studies that also looked at that question?
I believe we responded to one of the Green Mountain Care Board questions surrounding that, so I'm vaguely familiar with it, but I'm certainly not an expert on it.
Okay. Are you familiar with the Yale Hospital Pricing Project's examination of the relationship between Medicare and Medicaid prices and commercial prices?
I am not.
Are you familiar with the National Association of State Health Policy, their analysis of the relationship between Medicare and Medicaid reimbursement and hospital prices?
I am not.
Okay. Each of those has found the correlation between Medicare and the proportion of patients with Medicare and Medicaid at a hospital and commercial prices to be very low, less than 0.2. the CBO report in 2022, their finding was that as the proportion of patients with Medicare and Medicaid went up 1%, commercial prices on average went up 0.1%. So that association that our hospitals in Vermont and many others rely on is simplistic and makes quick sense, but is wrong. The numbers that you talked about with cost shifting is not to do with price. It's Medicare and Medicaid reimbursement rates compared to the hospital price, not the hospital cost. And because the hospital can set its price, the higher it sets the price, the greater the loss appears to be. I don't know that that would affect your rate request at all, but I think it's a very important thing that we all try to understand together. That the gap that is called the cost shift is actually the difference between Medicare, Medicaid reimbursement and a hospital's price. And because they set their price, if they have more market power, that gap will appear to be bigger. Those are all my questions and comments.
Thank you, Tom. Board Member Merman.
Yeah, thanks. Sometimes my audio is funny. I'm good, right? Thanks. Okay. One of the things that you discussed in your non-actuarial testimony pre-filed in today is your telemedicine program. Often there's discussion of the healthcare system being fragmented and that patients receive care in different places that don't communicate with each other. With your example that you gave of a young child with a fever receiving telemedicine care, do you have any concerns about that related to the fragmentation of the system?
Certainly, there can be times when telemedicine can increase fragmentation, which I think is what you're specifically asking about. But we also find there are tremendous benefits in being able to access care in a timely fashion and understand and triage care necessarily. So I think I would agree in theory that that telemedicine can potentially increase fragmentation in the healthcare system.
Okay. But you're sort of suggesting it's offset by the benefit of access and timely care.
That would be correct.
Okay. Different topic regarding what Tom was just discussing with the cost shift, which I kind of think about as the concept for hospitals to need revenue from commercial insurance to offset losses from public payers is often how it's described. Is there any role of a commercial insurance company to try to reduce the magnitude of this impact onto their ratepayers?
There's the role that we have specifically within that is to negotiate the best rates that we can for our insureds. So if there's a role that we can play in terms of understanding and impacting that overall revenue for the hospital, I don't know that we can directly impact it.
Do you think there's a one-to-one obligation of a commercial insurer to pay all the difference that the government payers revenue is under those commercial price underneath the prices set by the hospitals?
I don't think we have an obligation in terms of the marketplace, but there is significant pressure and there's significant leverage brought to the table in terms of those things, which make it difficult for insurers to negotiate.
What are those elements of pressure and leverage?
Sure. So I'm certainly not an expert in medical contracting. I defer to our contracting team on that. But if you think about a situation where a negotiation becomes so bitter or so bad that one one entity wants to leave the table and no longer wants, a hospital no longer wants to be in MVP's network or vice versa. Understanding that the hospital is the one who's primarily doing the care presents a significant burden to MVP and in terms of what happens when that hospital leaves the network. So members are more likely to stick with their hospital rather than stick with their insurance company, and they're more likely to side with their hospital rather than their insurance company in terms of care. So, there's significant leverage I would say significant negative leverage being brought to the table when an event like that may happen.
So it's said sometimes in our meetings, and I don't know if you're aware of this, that Vermont is different because the Green Mountain Care Board regulates the hospitals and sets those hospital increases, and therefore thinking about market power doesn't apply in Vermont. What do you think market power has an impact on negotiations with your Vermont hospitals?
Again, not a contracting expert, but I do think that market power always has a role in negotiations between hospitals and insurance companies.
Okay. You had mentioned that that the hospitals view the Green Mountain Care Board defined rate increases as a floor and not a ceiling. Do you ever negotiate prices paid to hospitals above the floor?
Not that I'm aware of, but I'm not privy to all of our contract negotiations.
Okay. So would you say there's no space between the floor and the ceiling? Is that what you're saying?
In general, yes, that appears to be the case.
Okay. There's been a bunch of discussion about healthcare costs rising over time a good bit today. Would you agree that healthcare costs are rising over time? I think you testified to that earlier.
That's correct.
Okay. And would you agree that healthcare costs are rising faster than other measures of inflation, such as wage growth?
That's correct.
Okay. Can you I think you said that medical costs are one of the factors that's leading to this rising healthcare costs over time. Can you expand on some of the specifics of these medical costs that you think are leading to rising healthcare costs over time?
Sure. So, I mean, just looking at our data, right, some of the possible drivers, and I won't say that all of them are actually existing and all of them are, to what extent they exist, but certainly the number of services that are utilized, particularly when we operate in largely a fee-for-service environment, more services being performed generally will lead to higher costs across the system. That goes for pharmacy as well. More drugs that are being used would also increase costs of the system. We can also take a look at services that are more intense. So, and I won't suggest this is happening at all times and in all places, but times where level 3 ER visits become level 4 ER visits, become level 5 ER visits. Whether that's actually the case or not, there are some places where services can start to go up over time, not simply because more services are being done, but because they are more intense. A lot of it too is we have, and this is not necessarily an actuarial answer that's related to MVP in particular, but we have, as a society, placed a premium on expanding care, expanding the lives of people, expanding the livelihood of people who are dealing with certain conditions, and so that comes with a cost. We have greatly increased, for instance, the number of treatments that go along with cancers to extend people's lives and extend the quality of life. So we've placed a premium on that as a society, and I do think that the cost is associated with that.
Okay. And one major area that comes up with us that you didn't mention is prices. Do you see prices for healthcare services rising over time?
Yes, we do see prices for healthcare services rising over time, and that's a function of both where the Green Mountain Care Board's budgets come in, but also just our negotiation with payers.
Okay. I want to talk a little bit about administrative costs. What percentage of the premium are made up, say, on either why don't we just take the small group plan? What percentage of the premium, the small group plan, are made up by administrative costs?
Sure, I'd have to look at our exhibit for that. So if you don't mind me going to, actually, probably the best place to go is the L&E exhibit, or the
Yep.
L&E memorandum, which is, I believe,
Exhibit 20.
thank you, Barry. So Exhibit 20, page 12, lays it out that it is 6.3% of premium for 2025.
Okay. And do you know roughly if that's been stable over time?
I think that's actually decreased over time. I can't speak to exact specifics, but in general, our admin increased by less than the cost of medical and pharmacy claims. So if you think of as the pharmacy claims are going up by more than the administrative expense every year, then the administrative expense becomes less as a percentage of premium over time.
Okay. And then this describes this table breaks out the expenses of the various administrative costs of healthcare, but each of these things, like you were suggesting, would increase at a lower rate than healthcare costs overall, right?
That's generally been the case, correct?
Okay. I guess my impression was that the overall MLS and the MLR ratio, the medical loss ratio, was about 90% for the medical side and 10% on the administrative side over time. Is that roughly what you've experienced?
Yes, somewhere in that. I mean, I think we quoted this year in my memorandum at somewhere in the 7 to 8% range, but historically, rounding, it's been about 10% versus 90% of claims.
Okay. So I don't have exact numbers on this, and I'm just kind of curious, which is why I'm trying to delve into this topic a little bit, that it dawned on me when I was reading through this yesterday, and this isn't complete through the years, but looking back a little bit at the small group premiums and the membership, and looking at the administrative costs over time, I didn't see the percent administrative costs, but if they were at this, I found 5.8%, I think is a number that we used earlier today. If that 5.8% number was fixed over the last several of years, when I actually look at what the administrative cost growth per member, this would be from 2019 to 2023, it actually appears to go up by like about 56%. But I guess you're saying that that 5.8% growth has decreased. I think I'd want some analysis into seeing how much your actual administrative costs have grown, because 56% sure looks like a heck of a lot more than inflation or wage growth during that time frame.
I'm sure we can pull that analysis together for you.
Regarding the MVP healthcare structure, so MVP Healthcare is the overarching company to the nonprofit MVP Health Plan that we're discussing today. Is
That's
MVP
correct.
Healthcare a for-profit or nonprofit company?
I don't know the answer to that off the top of my head. I'd have to confer with our financial team.
Okay. And I have one other question. It appeared to me that that MVP submitted Exhibit 29. Is that correct?
We had originally submitted it, but I believe it was
the non-stipulated exhibit list 29.
And that's not.
Yeah, Dave, that's one of the documents that was not admitted. There was some motion
Okay.
practice before the hearing.
Okay. Okay. Right. Okay. I'm going to stop there, but thank you.
Board Member Lunge?
Thank you. Good. I guess I can still say good morning if we have 4 minutes left. My first question is, in your direct testimony about Exhibit 27, you indicated that the 2024 estimates, there was a range of expected outcomes. Am I remembering that correctly?
And that's correct.
Would you be able to provide us with that range?
We could provide a potential range, but I'm not sure that we would have the ability. I mean, I'm an actuary. My job is to predict the future, but I don't have a full crystal ball. So we could certainly provide if you're asking for a range, I think that's something that we could provide.
I was just curious because you had indicated that it was within a range, but that made me wonder what is the range. So I think if that's something that you could give us a general sense of plus or minus what the range would be, that would be interesting.
Sure.
Robin, what exhibit was that? I missed it.
It is Exhibit 27,
Okay.
the historical rate summary. Yep. And specifically, I think the testimony was that the 2024 numbers, I think particularly around the impact on the losses was an estimate. I'm remembering correctly.
Thanks. I just for my notes, just wanted to
Yep.
clarify.
Yeah, sure. I had a couple questions about the price transparency tool. Do you know how many people use the price transparency tool on your website?
I don't, unless we quote it in our pre-file testimony. I don't know it off the top of my head.
I did not see it in the pre-filed testimony. Is it possible to just get a snapshot of order of magnitude? I'm just curious whether we're talking 10 people or 100,000 people.
It is likely less than 100,000 people, but yes, we can get a specific number.
Thanks. And you may or may not know this, given that this is not an actuarial question, but what is the quality stamp based on?
I believe that it's based on NCQA certification, but I would have to double check. I'm not 100% certain on that.
Okay, thank you. In your pre-filed testimony, you talk about the product design process as one place to think about affordability. And I was wondering if you could expand on that a little bit. In what way, what are you suggesting happen with the product designs?
Sure. Well, part of my testimony was to say that by the time we get to the rate filing and are done with the product design process, that our hands are largely tied in terms of what our benefits are going to be. And then the rate is largely a function of what those plan designs look like. So we would recommend any sort of plan design options that are new and innovative and would drive members to utilize care in a different way or tailor care towards a certain member. And obviously we understand, just like anybody else, that there are frameworks by which you have to provide certain services and you have to have cost sharing that fits into those specific plans. So one of the big ones is that we've actually filed a new gold non-standard plan this year and retired one of our old ones that has a little bit of a unique plan design. It's something that we haven't really done too much of yet. And so we're hoping that that plan will be tailored to individuals who specifically would like to utilize a plan like that.
Okay. And I believe you participate in the plan design process, don't you? Your company?
That's correct, yes.
Okay, thank you. So in looking at Exhibit 15, hold on, let me get to Exhibit 15. So with Mr. Becker, you talked about your annual statement, particularly page 14 about the Vermont business. And there was a discussion earlier around the the Vermont lines of business and the underwriting gains and losses, including individual, small group, large group, and Medicare Advantage. Could you crosswalk the numbers for the individual and small group market for 2023 in this exhibit to the numbers of losses in exhibit 27 for the individual and small group market for 2023? They do not appear to be the same, and I would have expected them to at least be closer. So can you explain to me the difference between
Sure.
those two?
I can explain to you the difference, and I'm not sure if I can fully crosswalk all of the dollars, but I can tell you what has occurred between the
Perfect.
filing of the statutory filing and this document. So the first one would be that this document, Exhibit 27, has more runout. So the statutory filings, we have to assume some level of IBNR, incurred but not reported reserves, at the end of the year. That goes into our statutory filing, and those claims always are not exact. Those are just estimates. So to the extent that there might be claims that have restated favorably or unfavorably, I would have to get back to you on specifics in terms of how the actual claims have come out relative to our expectations. That would be one area where we would see a significant driver. Another one is that not the Exhibit 27 would be impacting the underwriting gain or loss, but it is an area where they could be different. Finally, you can see here, if you go down to the bottom table, we assumed $8.1 million payment for individual and $5.8 million in terms of risk adjustment. The Exhibit 27 would reflect any changes to that from what we booked at year end. So to the extent that we understand that our risk adjustment position is different, then those might be different. So there's also, there's other items that are accrued for at the end of the year that are not reflected in here. That's the overarching item, would be that our financial statements are a moment in time as of year end 2023, and Exhibit 27 would be a moment in time as of or early July of 2024.
Got it. Okay, thank you. That was very helpful. The remaining questions that I have are for executive session.
Okay.
All right, Board Member Holmes.
Hi, great. Thank you so much. Some of my questions have been asked and answered, so thank you. Some I will reserve for executive session, but I do have a couple. If it's possible, could you turn to Exhibit 16, page 13? This will be question 27 of your pre-filed testimony.
Okay.
Great. So in question 27, which asks, what steps does MVP take to manage costs and contracts to improve affordability? Your answer there is MVP negotiates rates that reflect appropriate reimbursement levels across all provider types in MVP's network. Yes?
That's correct.
Okay. Could you tell me specifically how MVP determines whether a reimbursement rate is appropriate?
I don't have specific answers to that question. I'd have to take that back to our contracting team.
Okay, that would be very helpful. Because we know that you use words very carefully, right? So it'd be helpful to understand what is appropriate and how it's defined. On Exhibit 15, if you would go to that exhibit.
Okay.
And this is the response from MVP as it relates to the RAND. Compared across our commercial block of business, Vermont providers have consistently higher costs as compared to our New York providers on both facility and physician, including drug prices for physician-purchased drugs. And the Vermont commercial drug reimbursement is significantly above New York, in some cases 50 to 100% more. So I have a couple of questions here, but one actually, and maybe you're going to have to bring this back to your contracting team, would be helpful to understand why it would be appropriate to pay Vermont providers significantly more than New York providers for the same services.
Yeah, I would have to take that back.
Okay, well, I would appreciate an answer to that. And similarly, it would be very helpful to understand what is happening with physician-purchased drugs. I'm assuming that's what you're referencing there, or MVP is referencing in terms of Vermont commercial drug reimbursement. Is it hospital based drugs? Is it so? Do you have an answer to that, or is that something you have to take back?
I could get specifics, but my understanding is that it's primarily hospital-based drugs. So our negotiated contracts with hospitals produce pharmacy costs that are significantly higher in Vermont relative to New York.
Okay, so it would be helpful to me to understand which hospitals in particular, and also, again, I guess I would ask the same question: why it's appropriate to agree to a reimbursement that's significantly higher in Vermont than in New York. And I would say I have heard testimony, about floors and ceilings in negotiations with hospitals. Once the GMCB has provided hospital budget guidance or hospital budget order. And I would love to hear if you are aware of our specific language that we put in hospital budget orders. And I'll just read this one component of our hospital budget order. It says the commercial rate increase cap in paragraph B, referenced in our hospital budget order, is a maximum and is subject to negotiation between Hospital X and commercial insurers. Hospital X shall not represent that maximum commercial rate increase approved by the GMCB in paragraph B, or the expected commercial NPR based on that rate increase as the amount set or guaranteed by the GMCB in the hospital's negotiations with insurers. So that's language that we use, that we put in every hospital budget order, specifically to guard against that floor ceiling issue that has been raised. So I would also appreciate, I understand you're not on the contracting team, but I would appreciate a response from the contracting team to why that language hasn't seemed to work.
Yeah,
Is that something that you can do? Or if you have an answer to now, but.
We can take that back to our contracting team, but I want to clean up my testimony and say that we're certainly not accusing any hospital of coming to the negotiating table and saying this is the only rate that we will accept. It's just functionally how things are playing out. But I would have to get specifics from our contracting team in terms of efforts for negotiating.
Okay, I would very much appreciate that. And then I wondered if you, with all of the hospital and insurance price transparency data that is readily available on websites as a result of some federal regulation changes in the past few years, would you be able to share any analysis that MVP has done comparing the MVP negotiated rates with Vermont hospitals and, frankly, New Hampshire border hospitals, with the negotiated rates observed in those, price transparency websites of the larger out-of-state, and I mean out-of-state, national, to some degree MVP is out-of-state based in New York, but I mean here the Aetnas, the Humanas, the United Healthcare, the Cignas, all of those larger insurance companies. Is that an analysis that you have done?
We have not done anything national as far as I'm aware, and I don't think we've done anything in terms of New Hampshire. We have done stuff in Vermont, particularly related to the University of Vermont Health Network. I could potentially share the results of that study, but I'd have to go back to our network trend analytics team for that.
That would be very helpful. And it would be very helpful to see, just in the context of, national carriers, how do MVP's reimbursement, negotiated reimbursement rates compare? So if there's an opportunity to do that analysis and share it, it would be very helpful to us.
Okay.
Thank you. My next question is, and I know there's been several scenarios that have been proposed by the board in terms of looking at the premium impact of various hospital rates. And I'm wondering, I don't think I saw it, but please forgive me if I missed it. But did you do an analysis of if basically if rather than actual hospital submissions were implemented, but actually the budget guidance was implemented, where we capped commercial rate growth at 3.4%? Is that an analysis that you have in your scenarios that I've missed?
We have not done that as a scenario. That was not requested by L&E, but we certainly could do that calculation quickly and return it to you.
That would be extremely helpful. I would appreciate that. I guess my last final question really is, you had testified earlier how strongly MVP feels about primary care providers, how they're central to the patient medical experience, and access to a primary care provider is an essential component of care management efforts to promote affordability. And I guess my question is, does MVP keep track of the members that have no assigned primary care provider in their membership pool? I'll ask that first question. Do you keep track
Sure.
of people who don't have a PCP?
So depending on our company, whether it's MVP Health Plan or MVP Health Services Corps, we have different attribution methodologies that are either based on whether a member chooses a PCP, whether they're forced to choose a PCP by virtue of being in a plan, or we sometimes will attribute based on claim data for the past 12 months. So there's various attribution methodologies. I can't speak for certain for this line of business, but we do generally have PCP attribution in our data.
Okay. So it would be helpful to find out what proportion in this line of business of members do not have a PCP or have not visited a PCP, if you have it in a given year. Just trying to understand what kinds of efforts are made and what proportion of people are not actually accessing such a central component of that patient medical experience.
Sure, we can provide that, and I think it would be helpful to provide that as two buckets where a member is not utilized the PCP but also utilized other medical services, as opposed to somebody who truly just has not utilized the PCP. I think if I'm reading through your question, I don't necessarily want to say someone who is healthy is not utilizing their PCP and that's a bad thing. If they don't have any reason to, then we certainly would not want them to go. But for things like wellness visits and things, we could look at that.
That would be helpful. That's all of my questions. Thank you.
Thank you.
Chair Foster.
It appears from Exhibit 19 that your PBM has been fairly off in anticipating pharmacy trend. Why do you rely on the PBM if it's consistently wrong?
They have more significant knowledge than we do of the future-looking pharmacy trends. So certainly their knowledge is not, as you've noted, has been off the past few years, but they have more knowledge than we would, which would also enable us to support it. So we have to, again, justify our rates to both L&E and to the Green Mountain Care Board. So for us to say we have no idea, we're just going to pick a pharmacy trend, we at least have credible data in terms of relying on our PBM.
And is the pharmacy trend that your PBM furnished you and submitted to the board, MVP, is it reliable?
We view it as generally reliable.
And do you think it's reasonable?
I would say that it is reasonable.
The Medicare Advantage product, is it forecast to continue to lose money?
I don't have specifics in front of me, but that's my general understanding.
If the Medicare Advantage product was not losing money, would your rate submissions to the board be different?
No.
Is there any impact of the Medicare Advantage losses in what you're requesting to the care board in connection with the QHP rates?
There is not.
I'm sorry, my internet might have broke up. What was the answer?
There is not. There is no connection between the two.
Do any other parties share in losses from the Medicare Advantage product that you offer?
I would have to take that back to our finance team.
Are there any other parties that benefit from the Medicare Advantage product that you offer?
Once again, I'd have to take that back to our finance team.
The third one is, are there any other parties that contribute to the costs or work in connection with the Medicare Advantage product that MVP offers?
Again, I would take that back to our finance team.
Okay. In the last year, has MVP experienced any unanticipated claims surge?
Not that we've that's been observable and attributed to any one particular event.
What about just whether or not you're getting more claims than you had forecast?
I think that's generally the case. Just based on our premium rate submissions, 2023 was below what we would have forecasted. I think it's too early to tell in terms of 2024 data. The 2024 data at first glance does not appear to be above our trends.
And are you seeing any increase in the QHP claims in patient acuity?
We are not, but it would be too early to tell.
Okay. And in the claims, are you seeing any increase in the average length of stay?
I don't have that specific data point.
You testified earlier about generally the New York hospitals are less expensive for you for the services that are provided as compared to the Vermont hospitals. Yet the New York hospitals receive lower rate increases from MVP than the Vermont hospitals. Can you explain that? Why that is?
Do you mean, when you mean rate increases, do you mean premium rate increases in terms of small group and individual rate increases?
The negotiated rates with those hospitals, the change in charge increases for those hospitals being larger for Vermont, despite a higher base expense than the New York hospitals.
Yeah, I don't know if that's necessarily true. I don't know that we always have lower increases for New York hospitals than we do for Vermont hospitals.
Let me ask you a different way. When negotiating with Vermont hospitals, do you consider what I'll call their base level of expense? And by that, I mean what you're already paying them, whether they're high or low compared to other hospitals you contract with?
I can't speak to certainties in terms of how our contracting team handles that. I'll leave it at that.
Is there a contracting representative testifying today?
There's not.
The healthcare advocate in their opening statement made 3 recommendations. Not sure if did you catch that? Were you here for that?
Yes.
I wanted to go through each of those with you and hear your perspective as to whether or not they are sound or not, and why either way. So the first recommendation was for MVP to assume hospital, I forget if it's costs or NPR increases were consistent with the board's guidance?
So our position, as I stated previously, would be that if the hospital rate increases are aligned in terms of what's built into premium rates as well as what's built into the ultimate approved budgets, then MVP would be amenable to that.
The second one was to assume a 0.1% medical utilization trend.
So L&E did note in their filing that 0.1% would be an acceptable utilization trend. We did somewhat disagree with that in terms of their justification and their disagreement with us in terms of the impact of COVID. They also noted elsewhere that if a lower than proposed and recommended utilization trend was used, then a higher than current CTR or risk margin would be justified. So I would not say that we would not approve or not accept as reasonable a lower utilization trend without also a corresponding increase to the risk margin.
I see. Okay. And do you think the 0.1% medical utilization trend is within the range of reasonableness?
It is below the trend that has historically been seen in this block of business. And I believe it's below L&E's, what we relied on, which is a historical range of utilization trends that I believe is between 1% and 4%. So we would not necessarily agree that it would be reasonable.
And would you agree or disagree that it's within the range of reasonableness?
Based on the 1% to 4% range provided by L&E in prior studies, I would say that that's not within the range of reasonableness.
And then the third one that the healthcare advocate recommended was using the 7.4% RX trend that your PBM had provided. Do you think that's reasonable?
So we agree to L&E's recommendation. We do think that our trend would be reasonable. They also have a reasonable trend. The risk would be that if the claim costs continue at a level above what CVS, our PBM has projected, then we would be left short, and future rate increases would have to increase for that. So, if the trends come in higher than what we expected in our 2025 premium rates, when we go to use 2025 data to price, then that would have to increase our premium rates.
One of the fundamental problems, it seems to me, in our healthcare system is that the amount the insurance companies have to pay is too great. Like there is a minimal amount that we can save Vermonters on the insurance side of the equation. The costs that you have to pay, the claims you have to pay, they are what they are, and they're high. Is there anything, you spoke a little bit about some of the techniques and methods that MVP is using to lower that component. Is there any way we can, or you can track and be accountable for whether or not those actually work? And I understand that part of it is the care board is regulating cost containment on the hospital side, but what do you do at MVP to make sure you're doing the best you can to lower that component?
Yeah, so I'm not aware of anything that's done at MVP to track. I'll use prior authorization as an example to track prior authorizations other than the number that are approved versus denied. What impact that those have on future claim costs, I think, would be a complex issue that I know MVP is not doing anything currently to track. Whether or not that's something that could be done reliably, I can't speak to. So I don't know specifics in terms of how what could be done to further hold insurance companies accountable for tactics like that.
Is there anything MVP can do to promote care being moved out of expensive hospitals to less expensive hospitals, or from less expensive hospitals to community providers?
I will say that there are strategies. Our wellness benefit is one where it seems trivial, but every service that we can move out of a hospital because somebody took the initiative and started taking care of their health a long time before that condition occurred is something that can help. Certainly, MVP is utilizing other tools in terms of our cost transparency tools and those sort of things to be able to say we're putting it on the member to be able to have an active part in their care. But in terms of MVP telling a member you have to go use this facility rather than this facility, I think that's generally limited in terms of our ability to do that. Ultimately, the member is the care that is provided to a member is between the member and the doctor. And so to the extent that a doctor recommends that they go get this service, it's difficult for MVP and becoming increasingly more difficult for MVP to step in and say, wait, maybe that care is not the exact specific care that's needed.
If MVP is losing such significant dollars on the QHP plan, why do you remain in the market?
That's a question that's, I think, well above my pay grade. But I will say that we are evaluating all of our options as we do every year in terms of long-term sustainability in the market, whether we feel like these losses can be turned around, and doing everything we can to try to turn those around and be able to support our members for the long term.
Thanks for your testimony today, and it was nice to meet you. I appreciate your answers.
Thank you.
So, Mr. Carnady, I think I'm going to give you an opportunity for redirect, but we're also kind of at a good breaking point for lunch. So would you like to break for lunch and come back to that? Maybe get a chance to think about that for a minute, or are you ready to proceed with any redirect you might have?
No, I'm ready, and I want to do my redirect right now if I could.
Okay, then go ahead.
I have no redirect.
Okay. Then this is a good time to break for lunch. We should talk about the rest of the afternoon. It sounds like board members at least have some questions about confidential materials. We could go into executive session after lunch and then proceed with the DFR witness and L&E witness, or we could kind of put it on at the end. Does anybody have Mr. Becker or Mr. Carnady, any preference on that?
I would obviously defer to you, hearing officer, and the board members. I do think that it may be with different witnesses testifying afterwards, you would get a clearer picture of what they say about various issues, so that you go into executive session at the end and you can cover everything at once and have a full picture of it. That may be more efficient, be my thought. But I'll defer.
That's a good thought. So let's plan on that. Why don't we take 30-minute lunch break, reconvene at 1 o'clock. And Mr. Lucier, are you with us?
I am, yep.
Does that work for you to come back at 1 and start with your testimony?
Yeah, that'll work for me.
Okay, Ms. Morales, can we go off record?
Okay, we are off the record. The time is 12:30 p.m.
Okay, see everyone back here at 1 then. Thanks. Okay, before we go back on record, Laura, I forgot to ask if you had any questions for Mr. Bachner.
Thanks for checking in. I do not believe we have any right now.
Okay.
Thanks.
Okay.
Okay, can we go back on the record, please?
Sure. We are back on the record. The time is 1:03 p.m.
Okay, thank you. So next we're going to hear from Jesse Lucier at Department of Financial Regulation. Jesse, are you ready to take the oath?
I am. Can you hear me okay?
Yep.
Okay.
Do you solemnly swear that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth, so help you God?
I do.
Okay, then please go ahead.
Hello, everyone. Board, Mr. Barber, and Mr. Carnegie, and do we have the HCA, Mr. Becker, on? Good afternoon to all of you. For the record, my name is Jesse Lucier. That's JESSE LUSSIER. I'm an insurance examiner for the Department of Financial Regulation. Our role in the rate hearing is to offer a solvency opinion. We have two letters, one for the individual business and one for the small group business. They're effectively the same, except for in the final paragraph, the rates as they apply to each filing. I will just read some parts of the opinion. I'll start with the summary on page 1, and for reference, those are exhibits 17 and 18. And I'm on the first one, exhibit 17. The summary of the opinion on page 1, the proposed rate filed by MVPHP would not negatively impact its solvency, and the company otherwise meets Vermont's financial licensing requirements for a foreign insurer. When we go down to the second to last paragraph on page 2, titled MVPHP Solvency Opinion, there's a few bullets I'll just quickly address. As most folks are aware, insurance is a state-based regulation, and those states that the company is domiciled in are the company's primary solvency regulator. And in MVP's case, the primary solvency regulator is the New York Department of Financial Services. The DFR has not learned of any immediate solvency concerns from New York at this time. We also normally talk about and we have talked about, or I have heard, the percentage of business that Vermont represents for MVP. It is a smaller piece of business compared to their total business. But as DFR has said in the past, and we included again in this solvency letter, even though Vermont operations pose less risk to solvency compared to the overall New York business, the adequacy of rates and contribution to reserves are still necessary for all lines of business. And as echoed by other people, generally we would see all individual lines written so that they stand on their own. Each line should have an adequate rate and cover all the costs that an insurer incurs. And then finally, I will read the impact on the filing on solvency, which is the final paragraph. In its filing, MVPHP has requested that the board approve an overall average rate increase of 11.68% based on the entity-wide assessment above and contingent upon GMCB actuaries finding the proposed rates are not inadequate. DFR's opinion is that the proposed rate will not have a negative impact on MVPHP's solvency. The small group reads the same, except that it states the original filed rate of 9.34%. I've been listening to the rate hearing today, and I've reviewed the actuarial information as well as the other exhibits. It appears that there have been adjustments to the rate, and I think Exhibit 26, I can pull that up, outlines those changes. And from what I understand, and please correct me if I'm wrong, for the most part, LNE and MVP have agreed on those changes. I know there's some final adjustments that are to be made based on budgets, but assuming that that holds true, that LNE and MVP still agree at the final rate, then those changes would not, the changes to the rates would not change our final impact on the filing on solvency. And I think with that, I will turn it back over to you, Mr. Barber.
Thank you. Mr. Carney, do you have questions for Jesse? You're on mute.
So sorry. My partner, Ryan Long, will handle the examination.
Good afternoon, Mr. Lucier.
Good afternoon.
Frankly, I think you answered about 2/3 of my questions, so I'll keep it brief. I got to scroll down because, like I said,
I was hoping that would be the case.
Yeah. Could you please go to Exhibit 19, and that's LNE's report for the individual filing, and turn to page 19 of that document.
And I am there.
And I see 5 bullets. Do you see those?
Yep.
And keep a finger on that page if you could, or bookmark, and have a look at the small group version of the report at page 17. And if you could just confirm for me, the bullets are the same in both reports.
Yes, that looks correct.
And I believe you already said this, but you heard some testimony today that MVP generally agrees with all 5 of those recommendations. Is that correct?
That's my understanding.
Okay, and you also heard that from Mr. Bachner that the rates as proposed today incorporate LNE's recommendations, correct?
Correct.
And just to be clear, did you hear Mr. Bachner testify that with all of the adjustments from, I think, the date of your letter, July 12th to today, the rate for individual is 15.9%, and the rate we're asking for small group is 12.8%, correct?
Yes, and that's reflective in Exhibit 26 plus the other adjustment that they talked about, which was about 0.4%.
And I believe you would just testify that that really doesn't change DFR's opinion, and that the rates are adequate to protect carrier solvency. Is that correct?
Yeah, under the assumption that the final sign-off is agreed between LNE and MVP.
And just referring to your DFR letters, that last paragraph, that's that contingency you're talking about, correct?
Yeah. Yes.
Just above that paragraph, I'm looking at Exhibit 17, page 2, that third bulleted point. Could you read through the last sentence in that third bulleted point? I believe you may have read it, but just refresh for me.
Nonetheless, adequacy of rates and contribution to reserves are necessary for all health insurers to maintain strength of capital that keeps pace with claims trends and in turn protects policyholders.
Thank you. I think you may have heard Mr. Bachner refer to risk margin instead of CTR in his testimony this year. In the past, we've generally referred to risk margin as CTR, so I'll represent to you that where I'm asking about risk margin, I'm using that interchangeably with CTR. Understood?
Yep.
Could we go back to Exhibit 19 and turn to page 16?
Okay.
Just orient you, I'm looking at the Section 12 changes in contribution to reserves. And then I'd like to go to page 17. And could you read the very last sentence on page 17?
The very last sentence on page 17. LNE
Yep.
strongly emphasizes that reducing the CTR assumption from the filed 1.5% presents significant risk of inadequate premium rates that are not actuarially sound.
And as you sit here today, do you agree with LNE or do you have an opinion?
I'm not an actuary, but I would agree that that reducing the rate would generally increase the risk that rates would be inadequate.
Has DFR analyzed whether the rates would still be adequate if, for example, the board reduced MVP's proposed risk margin?
We have not.
Okay, so DFR has not provided in this rate review an opinion on adequacy of, for example, the rates with a 0.5% reduction to risk margin. Is that right?
Yeah, that's correct. We have not done any kind of actuarial calculations.
And so DFR is not offering an opinion on whether a rate with that reduction would protect carrier solvency, correct?
Correct.
And given LNE's report and the testimony you've heard so far about the most recent adjustments to the rates discussed by Mr. Bachner, does that contingency that we discussed at the bottom of your report still stand, or has that been cleared up?
I'm sorry, could you repeat the question?
I'll try. So given what we've heard today in LNE's report, you have a contingency in your opinion based on the opinion of the GMCP actuary. Now, has that contingency in your mind been satisfied?
From what I've been hearing during the course of the hearing, it sounds like LNE and MVP have mostly agreed on the rates. Effectively, they've agreed on them, and with the caveat that there's a few other minor adjustments. And I'm assuming it sounds like LNE would agree with those as well. So assuming that they agree with those, then yeah, that would satisfy the contingency.
Okay. So I have nothing further. I would just reserve and potentially recall at the end in case something comes up in the LNE testimony that we need to discuss. But nothing further for me at this time.
Jesse, are you able to stick around for the rest of the day?
I think so. I should be able to, yes. If I have to leave, I'll send you a message if that's okay.
Mr. Becker, do you have questions for Mr. Lucier?
Mr. Barber, no, we do not have any questions for Mr. Lucier, except that we would likewise reserve in case some additional questioning comes up after LNE testifies.
Okay, Board Member Walsh. Anything? Board Member Merman, do you have any questions?
I just want to clarify, you testified that the rate as filed would not risk the insurer solvency, correct?
Yes, and when I say the rate
adjusted file.
Correct, yeah.
Okay. And you have not done an analysis that if a rate was approved that was below this rate, the impact of that on the insurer's solvency, right?
Correct. We have not done any kind of actuarial analysis.
Okay. But you did do an analysis previously that the submitted rate would not impact the insurer's solvency, correct?
We rely on L&E to issue their report and the reasonableness of the rates, and then we look at, you know, if there's any discussion between L&E and MVP on the changes. So again, assuming that MVP and L&E are in agreement that the rates are adequate and reasonable, then we would kind of defer to L&E's opinion on that.
Okay, so you would defer to L&E's opinion that the rate is adequate and reasonable, but not comment on their solvency.
The assumption that is an adequate rate will cover the costs, and you know, if in a perfect world, the rate would be exact, and that the 1.5% CTR would go to MVP. So under that kind of assumption, then that wouldn't negatively affect their solvency. Does that answer your question?
Well, it answers that. Yeah, so that the rate, so the rate that is submitted wouldn't negatively impact their solvency, but I don't think we know of a range of a rate potentially below the rate submitted that would potentially lead to a negative impact on solvency.
Yeah, because the rates are not, I think as Eric said, there's no crystal ball here. So it's you know, the best estimates that folks can provide. And normally when you have two actuaries agreeing on it, that lends us more credibility that the rates are adequate and that there will be the minor contribution to reserves that has been posted.
Okay. I don't have any further questions. Thanks, Jesse.
Yep.
Board Member Lunge, any questions?
I'm all set.
Board Member Holmes?
No, I'm set. Thank you.
Chair Foster?
No questions.
Mr. Long, anything you need to clear up before we let Mr. Lucier go?
We talked a little bit about that contingency with the GMCB actuary. Does that contingency flow both ways? So if L&E recommends increases to the rate, you would take that into account into giving your opinion on solvency?
I think so, yeah. But generally speaking, we're more focused on whether rates will be inadequate. But sure, if there was if I guess if the rates were deemed to be if they were too high, then yeah, we would I assume note that.
And just to be clear, if L&E looks at the rates and says you need to adjust certain aspects of that upward, that would go towards your opinion on adequacy. You would tend to defer to them. Is that correct?
Yeah, correct. Yep.
Thank you. Nothing further.
Okay, you're excused, Mr. Lucier. If you could be available later, and if you need to hop out for something, please just text me so we can work through that. Okay.
Sounds good. Thank you.
Thanks. The next witness, I believe, is Jacqueline Lee from Lewis and Ellis. Jackie, are you with us?
Yes, I am here. Hi, Mike.
Hi. Let me just give me a minute to.
In me full screen?
Yeah, I put you on the
That's
screen
great.
here. Okay, I'm gonna swear you in at this point. Do you solemnly swear that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth, so help you God?
Yes. Yes. Sorry.
Thank you. And Ms. Belleville, please go ahead.
Good afternoon, Jackie. How are you?
Good.
And you can hear me okay?
I can. Thank you.
Great. So can you state your name for the record?
Jacqueline Lee.
And where do you work?
I work at Lewis and Ellis.
And what is your position at Lewis and Ellis?
I'm a vice president and principal.
Okay, if you could please turn to Exhibit 21 in the binder.
Okay, I am there.
And do you recognize Exhibit 21?
Yes, this is my pre-filed testimony that I provided on July 12th.
Can you briefly describe the information contained in the document?
Sure, it gives some background about me, about Lewis and Ellis, our experience in Vermont, as well as how we go about assessing the various assumptions and conclusions within the rate filing. Looking through to see if that covers it. And yeah, just the general process we go through in reviewing a rate filing.
Is the information in this document accurate and correct to the best of your knowledge?
Yes, it is.
And is there any information in this document that you'd like to change or clarify at this time?
No.
And do you wish to adopt this pre-filed testimony as part of your testimony today?
Yes, I will.
Can you please explain your role in L&E's review of MVP's individual and small group filings?
Yes, we have a team that reviews each filing. We set it up so that we have consistency year over year. So Tracy Hughes has assisted me for several years on the MVP filing. Allison Young began reviewing a year or two ago. And so these are all credentialed actuaries that are looking at the filing. They take first passes, have helped develop the questions that we will end up sending to MVP. I oversee all of those questions and responses, and then we, as a team that includes the Blue Cross team of Kevin Ruggeberg and Jason Doherty, we meet once a week to talk about the various issues to ensure that we're remaining consistent in our methodology and just thinking about all the issues, because some issues are market-wide where others are individual, and just ensuring that we have extra peer review as well across all filings.
Okay, and how do you submit your recommendations to the board?
We submit a report on day 60. Day 60 this year was also July 12th. So we issued a report. We issue one for each filing. So that's why we have two, an individual report and a small group report.
Right, and the report for the 2025 individual rate filing is Exhibit 19?
Yes, it is.
And the report for the 2025 small group rate filing is Exhibit 20?
That's correct.
So bearing those two reports in mind, do you have any changes you wish to make to either report at this time?
I do not have any changes I wish to make further to the reports.
Can you explain your standard of review in both filings?
Yes, we use our actuarial standards of practice as the basis for our reviews. There is a ASOP that covers how rate filings are supposed to be put together. We also use the board, has a standard that is reflected in our report, which is Exhibit 19. On page 4 at the top, we look at the aspects of that standard of review that include not excessive, not inadequate, and not unfairly discriminatory. And again, those items are defined within our ASOPs as well as within my pre-filed testimony. But those are the brackets we tend to review all assumptions and rates surrounding.
Great. And do you review for affordability in either filing?
We do not.
Using your methodology and standard of review, did you make any recommendations to modify this proposed filing?
Yes, we did. Those are included and have been referenced multiple times today on Exhibit 19, page 19, we made 5 recommendations. The same recommendations are made for a small group on Exhibit 20.
And would you like to briefly describe those?
Sure. We made 2 recommendations about unit cost. One was surrounding the inclusion of Brattleboro Retreat that was overlooked on the initial filing. We also made a recommendation, and this is a recommendation we've made nearly every year, that given the timing of hospital budgets, that those submissions that come in kind of right at our filing time for our report, that those are reviewed and considered in light of what might ultimately be approved. We also made a recommendation for pharmacy trend that's been discussed briefly this morning already, but we are recommending an increase to the pharmacy trend given our review, because we feel it is more of an appropriate assumption than the assumption originally in the filing. House Bill 766 is an increase as well because it was a new requirement put on the carriers that was signed into law kind of in the middle of the rate review season. So that needed to be incorporated because it will be effective within the 2025 time period. And then finally, risk adjustment transfers every year. We perform an independent calculation using actual information that CMS will be receiving each year that has been very accurate. There was a delay in the submission of these reports due to some of the issues with Change Healthcare and reporting. And so we did not have the reports prior to our Day 60 report. However, those did come out on Monday, and we have verified that our calculations are in alignment with the CMS report. And we made the recommendation that that be updated as a starting point for MVP.
Okay, so if all of your recommendations were to be implemented, can you explain what the ultimate projected rate increase would be?
Yes, we have an estimate in our report, but I'm going to reference Exhibit 22. Exhibit 22 is MVP's verification of that calculation. So for the individual filing, the initial submission was 11.7. And according to the calculation, it should now be, based on these recommendations, 14.9%, which is a little bit different than what our report states. The small group is the same. It is a 9.3 with a initial with a change to 11.5, which is slightly different than what we put in our report. And so we believe the 14.9 for individual and the 11.5 are more accurate calculations, but are based on the same recommendations that we've placed forth in our report.
And do you find the 14.9% increase reasonable in the individual filing?
Yes.
Can you let us know why you find it reasonable?
Yes, as stated before, our standard of review includes not excessive, not inadequate, and not unfairly discriminatory. And based on our review, the 14.9 falls within that standard.
And do you find the 11.5% increase reasonable in the small group filing?
Yes, I do.
And can you again discuss why you find that reasonable?
Yes, it's for the same reasons. We did the same review and assessed up against our standard of review and came to the same conclusion for the 11.5.
Have you reviewed the other pre-file testimony in this proceeding?
Yes.
Have you listened to the testimony today so far?
Yes, I have.
So after reading the carrier's pre-file testimony and all of the materials that have been submitted so far in the filing, and then listening to today's testimony, is there anything you wish to add or change to the 5 recommendations for the individual and small group filings that we have covered so far?
No.
And if your recommendations as of today are implemented, do you believe that rates would be excessive?
No.
Do you believe they'd be inadequate?
No,
And do you believe they would be unfairly discriminatory?
no.
I have no further questions at this time.
Questions from MVP?
Yes, thank you very much. Hi, Ms. Lee. How are you today?
I'm good. How are you? Good to
It's
see you.
nice to see you as well. So I want to walk through a couple of things. First, I just want to start with, you looked at Exhibit 19 and Exhibit 20. Those are the two memorandums from L&E. 19 is for individual and 20 is for small group, correct?
Yes.
So as in prior years, I'm going to ask you questions, and the questions would relate to both. We may just be looking at 19, but please correct me, but I'm going to presume that your responses relate to both filings. We on the same
Yes.
page?
Yes, I'm on the same page. Thank you.
Thank you. So starting with some concerns you expressed about losses. If you go to Exhibit 19, please, in your binder, and it's pages 16 to 17.
Yes, I'm on those pages.
Thank you. So first, you heard me ask some questions of Eric regarding the use of the term risk margin. I just want to talk about that term first, just so we get apples to apples. So the risk margin here in your report in the table is 1.5%, correct?
Yes.
And I'm at page 16, that table, the first table. And then you reference again the risk margin of 1.5 in the third paragraph, correct?
Yes.
And then if you go to the next page, there's a table and then there's a sentence below the table on page 17. Do you see that?
Yes.
And it says MVP's filed base CTR of 1.5. My question is, does that 1.5, is that referencing the risk margin of 1.5 on the table on page 16?
Yes, it is.
Thank you. And the bad debt, that 0.3%, that's separate and apart, correct?
Yes.
And the table above that paragraph on page 17, where it shows where MVP falls, those will be risk margins, correct? Well,
Yes, it's actually called profit in the profit and risk in the URT, which is the actual number where that is coming from. But yes.
Thank you. It's that number is the same number. And we'll just, you and I will avoid the words that you reference on page 16 next to risk margin, correct? The 1.5.
Yes. Yes, that's correct.
Thank you. Okay, back to page 16. And now that we have our words straight, I want to ask you some substantive questions. You'll see on page 16 at the bottom, the last paragraph references the reasonableness check. Do you see that?
Yes,
And that's something that L&E has done for the past few years, correct?
that's correct.
And just briefly, tell us what that's about.
So CMS requires as part of filings for any qualified health plan that is operating on the exchange that they file a URT, which is the Unified Rate Review Template. So most states and filings will have this template. They aggregate that into a public use file. And as I said a moment ago, there are different data elements. And so we have pulled the profit and risk data element for all the filings that are submitted to CMS. And so 377 carriers were, or URTs were, well, I guess let me stick with carriers. 377 carriers provided data for 2024.
And that would be nationwide, correct?
It is nationwide. There are some states that are state-based exchanges that may not include their data, and so there's some nuances, but it is a good portion of nationwide, and we use it very frequently in our work to just get an overall assessment of the individual and small group market.
Would you read the last two sentences of that last paragraph on page 16, please?
Sure. The filed CTR varied from minus 17% to plus 8%, but most often fell between 0% and 5%. The premium weighted average CTR for all carriers was filed as 3.0%.
Thank you. And then would you go please to the next page, page 17? And if you could explain the percentile in the table and what it shows where MVP falls as it relates to risk margin.
The graph at the top is a pictorial version of the data that we get from the public use file, or the PUF. And what it is trying to outline is, of the 377 carriers, how many fell within the buckets that are listed at the bottom. So for instance, it looks like there's about 51 who fall between 2.5% and 3%, which is why we said that the rough average is around 3%, because there's a good chunk that's within there. But mathematically, we did that differently based on premium weighted. But basically, it is trying to showcase where, if you pick a number, so 1.5, which is where MVP is, you can see how many carriers fall below it and how many carriers fall above it, and where they sit on a percentile basis. And for the 1.5, it is around the 20th percentile.
So that's on the low end.
That is on the low end.
Okay. And I don't know if you would recall, but that's even better than last year when this was done and MVP was at the 23rd percentile. First, do you remember what I said? And second, do you agree with me?
I do remember what you said. I would have assumed that if it was 23, and yes, this is a less of, they have a less percentile, so they're kind of even lower than they were last year if they were at 23.
I'd ask you to go to Exhibit 48 in your binder, please.
Yes, I have exhibit, sorry, I have exhibit 48.
Okay, I'm just going to identify it. This is L&E's individual rate filing. It's an excerpt of it from last year. So if you look at page 1, you see that says July the 5th, 2023. Do you see that?
Yes.
And then if you look, the last two pages, they're referenced page 17 and 18. And this is the section 12 on changes in contribution to reserves. Do you see that?
Yes.
And do you, I'm not going to hold you to every word in this, but do you recall this from last year, this filing?
Yes, I do.
Okay, so if you would go to page 18, please. And would you please read the first sentence below the historical RBC ratio, the paragraph below first sentence?
It is slightly concerning, that sentence.
Yes, please.
Okay. It is slightly concerning that MVP has experienced an overall negative profit in the last few years, and there was a significant decrease in RBC in 2021.
Thank you. Next, I want you to go to Exhibit 19.
Okay.
Excuse me, I grabbed the wrong exhibit. Exhibit 19, and I want to look at the same section. Look at page 17. And read that first sentence, please.
It is concerning that MVP has experienced consistent material losses in the last few years. However, MVP's RBC has been steadily increasing in recent years.
So I want to ask you first about, a year ago you said it is slightly concerning and then referenced losses and profits. This year you're saying it is concerning. So can you understand, or could you explain that and have your opinions change, and do you have greater concern, and why?
I would say my opinion has changed slightly in that it has become more apparent that these losses are continuing to happen. And it seems to be moving into a place where it feels unsustainable. The fact that last year, I probably could have modified that sentence given the RBC was actually declining at that time. But it just feels like there are aspects of this filing as it relates to the pharmacy trend where there has just been historic under projections that this is becoming a consistent issue and is obviously impacting the profitability of this block.
Thank you. And then if you go back, I'm sorry to go back and forth, but go back to Exhibit 48.
Yes.
And we'll go to that paragraph again. And would you please read the last sentence in that paragraph?
That same paragraph.
It's given this information, that sentence, please.
Given this information, Eleni believes that a CTR between 0.5% to 3% would be considered reasonable.
So that last year you provided a range around the 1.5, both below and above, correct?
Correct.
So let's go to this year. It's Exhibit 19. Go to that same paragraph and please read the last sentence there.
Eleni strongly emphasizes that reducing the CTR assumption from the filed 1.5% presents significant risk of inadequate premium rates that are not actuarially sound.
That's strong language for coming from an actuary, would you say?
I would agree.
So why the change in language? I know you touched on that a moment ago, but could you explain, please, why the change of language?
Again, I think it goes back to a holistic review of a lot of the assumptions that have been, that as we were reviewing the assumptions, I think the most alarming being the pharmacy trend and continuing to rely upon the PBM. I think that the increase in the change that we increased it helps with that, because to me, it puts in at least a good faith effort to go beyond what the PBM has been recommending. However, there have been even more losses than that. And I think that while I didn't see it prior to the report, I do believe that I believe it's Exhibit 27. While I have some questions about some of the numbers, I think the story remains that there have been significant losses on this book of business for the last, I guess it's 5 years. And it's just continuing. And a large part of it, you know, as demonstrated here, has been board cuts, there have also been equally that the rates have just not been adequate over the years, just from what MVP had requested. So in light of that, I feel that we needed to be stronger in our language, recognizing that it is a small percentage, but as noted, it would be really good for the market as a whole and MVP if this would be sustainable on its own.
And you referenced Exhibit 27. What you just expressed, that opinion, that includes, and I know the numbers aren't exact, but that would include estimates in 2024 where there appeared to be some profit for that year. You're looking at the trend. Is that fair?
That's fair. I'm not really looking at individual years. I think it's more about the amounts. And then, like I said, in coupling that with the fact that we've had serious concerns about the assumption setting in the past as well. And then seeing the pharmacy, there was no change in the methodology of the pharmacy trend assumption setting, just wanting to ensure that we, again, try to get MVP to have an adequate premium, which has just appeared to not be the case for the past several years. And again, independently looking at this filing, it didn't feel like it was.
And going back to Exhibit 48, last year, the CTR, I'll say risk margin, you said it could be reasonable between 0.5 and 3. That could be considered reasonable. This year, you're saying don't cut it. That would you strongly emphasize that presents significant risk, correct?
Correct. I believe it is a risk to reduce the CTR risk margin below the 1.5 this year.
Thank you. Okay, let's go back to Exhibit 19. The last paragraph before the RBC ratio table, excuse me, after the RBC ratio table, so sorry. And would you please read the third, fourth, and fifth sentences? And the third sentence, to help you get your bearings, starts with Vermont business accounts.
Exhibit 19.
Yes, Exhibit 19.
17.
Page 17. And it is under the historical RBC ratio, there's a long paragraph that starts,
Yes.
is concerning.
Yes. So,
So I would
however,
Let me frame it. Yeah, let me get you the right spot. I appreciate it. Yes, however, go ahead.
Okay. However, actuarially sound rates are sustainable without other subsidization. Eleni notes that it is not sustainable to have long-term losses and therefore a higher CTR could be justified. Keep going. Keep going, Gary.
I'm sorry, I was thinking.
Oh, okay.
I'm slower than you. Let's talk about those two sentences. What are you saying there? Can you explain it to the board?
Yes, I think Eric also covered this as well quite well, is that each product that you are offering in a market is supposed, from an actuarial perspective, should stand on its own. There are times, especially early in a startup, where you expect to have losses, but the ultimate goal is to achieve profitability and have that profitability be able to rely within its own product and not have other products be profitable so that you can see a loss in the product itself. So to have a goal to make the profitable, like if this was their only book of business, they would be profitable because it stands on its own.
So you heard some questioning by counsel for the healthcare advocate of Eric, looking at the larger company, MVP's financials and questions of profits. Would you agree with me that as an actuary, you're looking at that product line and that's what your focus is on in terms of actuarially reasonable rates?
Yes, we are focused on the product that has been filed.
I forget which sentence I had you read, so bear with me. I'm going to read the sentence to you. Eleni notes that it's not sustainable to have long-term losses and therefore higher CTR could be justified. What do you mean it's not sustainable to have long-term losses?
Again, if you have this as your only product line, you can't just have losses indefinitely. At some point, typically businesses assess whether or not they should continue to offer a particular product. And so it is not, a company cannot continue to remain in business when it's not making money. And if it has a product that is causing this, changes need to be made, whether that is they need to increase the premium, decrease the benefits, or simply stop offering it.
Thank you. The next sentence, given that a lower utilization trend assumption could also be justified as discussed previously in this report, Eleni is not recommending a higher CTR. Is your point there that if you set aside the utilization trend, if you didn't consider that, you would be recommending a higher CTR?
It is likely we would have recommended a higher CTR, yes.
And all this testimony you've given about long-term losses and sustainability, all the more important when there's only two carriers in the particular market, correct?
Yes, I mean, that's not part of our overall review, but it does hurt the market if, say there were to be one. That happened in a lot of markets early on in the ACA after it established, and it was not good for consumers.
Thank you.
So, Carly, can I interrupt just for a second? Just being mindful of time, we spent a lot of time reading the pre-filed testimony from Ms. Lee. I just want to make sure you're focusing where you think it's most useful for the board to get the information. Some of this seems pretty basic to me, so we might want to just be thoughtful of the time.
Chair, I appreciate everything you said, except I couldn't hear what you said. Some of it seems pretty, are you saying repetitive? I didn't hear what you said. It cut out.
Repetitive, and I think it came through in the report quite a bit. A lot of this, we get this, so it might be good to just focus on the key material if you think there's